Aloha, and welcome to The Creative Life, a collaborative production between the American Creativity Association, Austin Global, and Think Tech Hawaii. I'm your host, Darlene Boyd. Our guest for today is Dr. Sally Dang. Our topic for today is advocacy for blind and blinding veterans, and our guest, resilience from the most horrific tragedies leading her commitment to this cause. Stay tuned, and we'll be right back. Our guest today is optometrist Dr. Sally Dang. Sally is a recognized leader in both optometry and clinical leadership at local, regional, and national levels. Her leadership positions include Service Chief of Optometry at VA Long Beach Healthcare Systems. Sally joins us today from Long Beach to talk about the dramatic needs of our blind and blinding veterans. Because this is the Creative Life series, she is also willing to talk to us about her very personal resilience from horrific tragedy and her creative process in design, development, and delivery of VA hospital programming for blind veterans, as well as her personal advocacy for the ongoing needs of blind veterans. Sally, it's my pleasure to have you join us today, and I'm so appreciative that you're willing to delve into this with us. I think it's certainly a very important topic for many of us to learn more about. So, but I'd like to start as we talked about your resilience and the horrific tragedies in your life. So let's take a minute or so to talk about you personally and how your horrific life situations influenced you to grow in your commitment to our veterans. You were Vietnamese, and you have quite a story to tell us about coming to America, including a little piece of Hawaii in that story.
Yes, thanks, Darlene, for having me today. I'd be happy to share my story a little bit. I came to California via different places, including Malaysia, Guam, and Hawaii in 1975 when the fall of Saigon, now Ho Chi Minh City, took place, and we were refugees. And then we became sponsored by families that allowed me to get on my feet for school, and my dad to go back into his career, which is a physician. He was a physician in Vietnam, so he went back to school here in the States. And then he was able to get us back on our feet and provided us with education. So with that, we almost lost some family members, and we did lose friends and family during this transition to the States back then. But we all met up in California, and now we have a great family support in mostly Southern California. How I got to the VA is actually a long process as far as my career goes, but it's not an ideal situation. But in the process of going to optometry school back in the 90s, I had always wanted to be an eye doctor after I turned 16. So when my dad lost part of his vision, he couldn't see. So at the time he was a surgeon, and that was the livelihood of our family. So being scared and confused, I didn't know what was going on. So I thought I wanted to be an eye doctor so I can help people see better, and also understand how he lost his vision. So fast forward, I went to optometry school in Boston, Massachusetts. I met my then husband, was the classmate, and he was in the military. So when we graduated, we served in the Army. So my husband was tragically killed in Iraq in 2004 while he was serving with the Civil Affairs Public Command. So he, at the time, was an optometrist also, but he was also there to rebuild the infrastructure of the hospitals in northern Iraq when he was tragically killed. So that was the beginning of the Operation Iraqi Freedom. Since then, since I always had a passion and interest in working with low vision and blind individuals since school, my husband Rob, he knew that that was my specialty and desire to do. So we had agreed that I would be able to go down that route when he returned from Iraq and started my own center.
Am I
So,
correct that you're a different kind of optometrist than the common stock optometrist?
oh yeah, I'm a low vision. I'm an optometrist, but I specialize in low vision rehabilitation. So mostly patients who have permanent vision loss.
And you mentioned that your father lost his vision. How did that occur? Was that just the natural, or was that?
It was something that happened. Usually, the disease he had, there is no reason. There's no ideology for how it happens, etiology as far as how, but knowing what I know now, based on what I knew then, I didn't know anything then, but now um, what he had was something that was a very acute, needed immediate emergent care. And he regained most of his vision. Well, he regained 70% of his vision in one eye, and the other eye is still visually impaired. So he did have to change his career a little bit after that, as far as the medical profession or specialty.
When you tragically lost Rob, how many children did you have at that time?
I had two boys, 7.5 and almost 10. And then I was expecting another son. I was 8 months pregnant. So,
And I think you had told me that that was somewhat of a high risk pregnancy also at the time.
yeah, it was high risk. It was a stressful pregnancy leading into the delivery because the whole year that I was pregnant, Rob was either in training or had deployed.
Uh, why service to the blind? Beyond your father, certainly your father's condition motivated you, but
I think it goes back to when I first learned about what the specialty of low vision was back in school. I didn't really know the differences of what different eye care modalities were. I didn't know the difference between um, like optician, optometrist, ophthalmologist, the specialties that they each carried. What I did know when I got to optometry school was that I picked the right profession because I wanted to work with people who had vision loss, mostly because no one else was wanting to do that in our class. And it's actually a very small percentage of optometrists or eye care professionals that do low vision rehabilitation. It's a very unique but highly needed profession. It's just that at times it's difficult to work with patients who are um, they're definitely vulnerable, and it's really not easy to communicate or touch a patient in the way that they want you to. A lot of patients don't want to ask for help. They're either afraid, they have fear, they haven't resolved that loss. They don't want to bother or be a burden to anyone. But then in the end, it could be a burden on the economy because we could have more costs when they fall or having caregivers. So it is a public health burden. So I guess I always wanted to help the ones who wouldn't get the help that they needed.
is there an age range for low vision, or can it happen at any age?
It can affect anyone. Most of the patients are over 50. Right now, around the world, there's about over 2 billion people that are affected by visual impairment that can still be helped so that they can at least use part of their vision for visual function. And there are children that are affected, but mostly by physiological or inherited or birth trauma.
What are some of the, you mentioned physiological for the young, for children? What are some of those kinds of categories?
Prematurity of retinopathy, so just having early retinal detachments, cataracts or trauma during delivery, glaucoma that eventually leads to blindness, congenital diseases that has been passed down through the family. Although a lot of them aren't sudden vision loss, they're usually progressive, and depending on how quick they progress is when you can determine the outcome of their visual function. So most patients that I see in children who have a visual condition, if they get early rehabilitation, they could be very functional. They could go to school. They may not drive, but they can still be very literate in reading, writing, computers, technology. So I've met so many brilliant people who lost their vision in their teens because of disease that they acquired or congenitally acquired. But it's usually early intervention is usually the best outcome. And a lot of people, unfortunately, around the world, even in the US, we don't have the resources to get those early interventive needs as far as rehabilitation or devices or technology, because there is a lot out there. It's usually the awareness that we don't, that isn't available to the general public, and also it just becomes a resource that's not funded. But and the leading cause of blindness, so out of that 2+ billion, half of those eye conditions can be prevented. Like, for example, diabetes is a leading cause of death. I mean, not death, cause of blindness, and also comorbidities and other things. Age-related macular degeneration, you may have heard, that is also on the rise with our patients and our elderly living longer lives. And cataracts in areas that we don't have intervention or surgery in different countries, that is a leading cause too, just because it's part of the aging process. That's probably one of the safest needed surgery that can save the vision. There's a lot of other diseases, but those three and glaucoma are mainly the main leading causes of visual loss right now.
You mentioned diabetes, and I suspect most of us know that it is not unusual for people to be connected to diabetes and the oncoming onset of blindness. Why is that? Diabetes certainly affects sugar and glucose in our bodies, but why can diabetes be the forerunner to blindness?
So the capillaries in our eyes are directly connected to the rest of our body. So when diabetes presents in the eyes as a retinopathy or a disease, then it's usually because there's really poor circulation in the rest of your body from the complication of diabetes. So once the circulation is impaired in most of the body, you've heard of a lot of people having foot pain or chronic disease in the feet. So the other part is the eye. So those are the two extremes of how diabetes travels. So when it gets to the eye, it does become very dangerous because you can have bleeding and detachments, and leads to complications. And once those vessels, those blood vessels in the eye are damaged, or they burst, or you can't repair them. And we only have so much in the eye. So once it's permanently damaged, it just leads to permanent vision loss. It's like having blood vessels under your hand or your arm, but in your eye, you can see the blood vessels. So if you were to sever it or, cause stagnation in the blood circulation and supply, then the eye won't get what it needs to oxygenate. So it's just diabetes is a very complicated overall circulatory disease.
Without a doubt. So you also you're quite a bit of claim to fame for your partnerships with other VA hospitals, and also I think it would be nice to mention that if I'm correct, the VA hospital in Long Beach is named after your husband.
The The Blind Rehabilitation Center is called the Major Charles Robert Soltis Department of Veterans Affairs Blind Rehabilitation Center. So that was a bill that was initiated by blinded veterans, and he was the first optometrist killed in action. And because of my work with low vision, individuals put the pieces together and thought it would be great to name that building in his name and his honor. So at the time, I wasn't prepared to work there. I didn't plan to, but when it opened in 2012, I was asked to come help set it up, and I've been there ever since to help grow the program and other eye programs as well.
What a wonderful testimony. It's certainly nice to know that was possible to carry out. So let's talk about the veterans in our hospitals. What kind of treatment do they receive, and is their treatment available to them at no cost, or is it available to any veteran?
Yeah, so they have to be eligible to get care in the VA hospital. So once they're eligible, then they can get all the treatments that are available. And as far as vision rehabilitation, the VA is the only health organization that provides that for the veterans without additional costs for the devices and the programs. And we have an inpatient program, so that's a really great resource for people who are losing their vision or has functional vision. So the difference between complete blindness, I often get questions, how blind is blind, and or what does it mean to be blind? Do they have a little bit of vision? And being legally blind is a certain criteria that you have to measure on the chart when you're reading the chart. So without getting into the technicalities, it's so legally blind, it's really mostly because for Social Security or having a legal definition for it, but it's really outdated a little bit because it doesn't mean you're completely blind. It just means you're legally blind. But a lot of patients who are below that mark can also be visually blind, as you could say, but blindness, when I say blind, it's actually having no vision at all. So if you have low vision or severe vision loss, so we have mild, moderate, and severe categories. The patients that have moderate, mild, and moderate, and partially some severe, those patients are all curable as far as low vision aids and devices. So let's say reading is the number one goal of a patient that wants to read again, but they have a permanent loss that regular glasses can't help them see again. So this is when we turn to low vision devices, and that comes in different forms and ranges, depends on your ability to utilize your hands and your eyes and cognitive function. So there's a whole toolbox of what we can do for you to read. That could be another show, but there's a lot out there that people don't know about that is beyond just regular glasses. So imagine the voiceover on our cell phones now, or even when we push play on anything, it can read to us. So that technology was pretty much established for visually impaired years ago. And now it's just become an accessibility for all of us who are just lazy to read or have no time to read. But these patients who can't see, they actually rely on this. And so when you bring it to patients that need the technicality of seeing or hearing better, it's really designed for these patients. So it's only getting better and better because our technology is improving. We have devices where if a patient is severely impaired and totally blind, they can wear an optical coherent device over their ears, and it's tiny. It looks like a little tiny hearing aid, and you won't really see it, but it's a little camera that that tells you where you're going. It's like a GPS system.
Well,
So
interesting.
this GPS system can tell you if you're going to be hitting a wall or there's a sign, it'll read it to you, and the patient hears it in their ears, so we don't hear it. And so they would get the training for that. So they can just be walking along with their cane and can hear what is coming ahead and danger zones and stuff. So that's not available to everyone, but we have it at the VA for our veterans. So it just depends on your level of impairment.
Since we are talking about our veterans um, and the tragic loss of your husband at the time, Rob, how what proportion of patients that you see in the hospital are suffering from your husband? You lost your husband to a suicide bomber, and there are other dangers. So, what percentage actually have an injury to the eye by an external source?
Oh, okay. That's an interesting question, perspective, because so during Iraq and Afghanistan, during the conflicts, we had a lot of veterans coming back with injuries that are blast related that led to a lot of different, it could be limbs lost, but a lot of the vision was related to traumatic brain injury that was usually from falls, or it could be from blast injuries. But the complications are pretty. It's like we call it the invisible wound. So traumatic brain injury is the invisible wound that no one really can see, but the patient experiences a lot of difficulty. So in my world, when I got to the VA and we were starting to see these patients come back from the war, um, they would have symptoms of not being able to read or see, or sensitive to bright lights, a lot of things. But when you test them and look at their test results, they test normal, they look normal, their performance, their test results look normal, but they just can't piece it all together functionally. So processing is definitely the reasons that they can't see. So we do help those patients see better by treating the symptoms. A lot of veterans that were young in their late teens and early 20s were coming back and couldn't go back to school or get jobs because of their visual function. So even though they could see, they just couldn't function with their eyes and their brain processing. So words may jump around on a page. They might see double vision. They can't retain what they're reading. They can't remember what they're reading. They lose track of what they're reading, so they have to reread something again. Words float off a page. These are very common symptoms of patients that have these traumatic brain injury deficits. And so that, I would say, I can't quote the whole, I would say that there's probably almost 3 million veterans that were affected with just that traumatic brain injury and vision impairment. And that's not even the retirees and other patients that were suffering long-term disease of the eyes. And I myself saw in the first 3 or 4 years, like close to 800 patients that had these visual symptoms, but I couldn't see all of them myself. So we started getting more people in residence. So we had a training program. So now we have students that are residents that actually are seeing a lot that they would normally not see on the non-VA sites. So we have a very diversified eye care population.
With wonderful results. Do you feel that do the veterans feel that they receive appropriate benefits?
I think the ones that we see, they're very grateful, and they actually say that they never thought that they would have been able to get the care that they got when they got to the VA. It's really just getting them to the VA, and then a lot of care can be given to them. The resources that are not available, I would say if the VA doesn't have a service and we send it out to the community, and the community, it's unpredictable what care that is. But right now, what the VA is doing is holding a lot of people accountable, including providers and staff, to care for these veterans. So I would say that there are resources to care for them. It's just getting them in the VA, to get the care first.
And Sally, we know that you certainly are a strong advocate to improve these situations and to help people to see again and to do above and beyond in your advocacy efforts. So where are you now as an advocate for veterans?
Where am I? I would love to see nationally everyone doing what the VA is doing. Well, I mean, I'm a little biased because at Long Beach, we've done a lot of work with getting access and accessibility for all eligible veterans who can't see. We're piloting new programs. I never take no for an answer when they say we can't do something. So we show that we can, and when we show that we can, things just come to us. So it's really, the demand is there. So I would love to be able to share what I've done at Long Beach with other centers or sites or areas that don't have that, have the resources or the means. But that's going to be one of my upcoming roles, is to help advocate for the military and the VA to have vision rehabilitation and to care for the traumatic brain injury as well.
And so that would be your dream. And it's also my understanding that you are already working with other VA hospitals across the country. And you also had an international partnership, did you not?
Yeah, I would say I am contacted by a lot of other VAs to ask questions and to share my practice and share best practices. I am part of the Vision Center of Excellence. I was a consultant since 2018 to just help identify the gaps and the barriers that there are between the federal services and the private sector and the public sector, and then the VA and military health agencies. So in doing that part-time as a consultant for Vision Center of Excellence, it has given me a lot of opportunity to see more, and I'm hoping that I can make more of an impact by doing that full-time. And that would be something that I'm working on to get to.
Oh, I'm sure you will continue to work on that, and there will be many successes forthcoming. We've come to the close of our short time that we have together, and hopefully in the future we'll have you back. And we sometimes get some questions as a result of appearance of a guest, and we'll see if we could address that in the future down the line in a few months. Thank you very much. And for those that have been watching, you have been watching The Creative Life with your host, Darlene Boyd, and guest Dr. Sally Dang, as we discuss the needs of blind veterans. Mahalo for joining us, and join us in 2 weeks for another episode of The Creative Life. Aloha.
Thank you so much for watching Think Tech Hawaii. If you like what we do, please like us and click the subscribe button on YouTube and the follow button on Vimeo. You can also follow us on Facebook, Instagram, and LinkedIn, and donate to us at thinktechhawaii.com. Mahalo.